Meet. DUR board members reserve questions until the end of presentations or ask in the Google Meet chat. Also, for those providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process. And thank you. And let's see here. Thank you, Noon, for recording the call. And I will turn the time over to Dr. Weinstein now for the rest of the meeting.
Good morning. Welcome to our October meeting, and want to welcome you. And if we have any specific housekeeping items other than what's just been reviewed, Luis, anything else for housekeeping today?
Yes, Dr. Weinstein, thank you. So for housekeeping, we do have a new Medicaid pharmacy director, and his name is Thomas Davies, Dr. Davies. And I don't see that he is with us
right now. Luis.
Oh, you're here. Thank you. And I will give you the time over to Tom to introduce himself to the board.
I appreciate that, Luis. So my name is Tom Davies. I've been with the Medicaid team now about 3 weeks. Prior to joining Medicaid, I was within the commercial space for about 4 years. And then prior to that, I was the pharmacy director for PEHP Health Plan here in the state of Utah. So very nice to be back in the state. Nice to meet everybody.
Great. Thank you. Thank you so much. It's great to have you, and welcome. Also, I wanted to let everyone know that we have a new consumer representative DUR board member, Mr. Cordero Baxter, and he was officially appointed as of 9/1/2025. And I'm not sure if I see him on the list as in the meeting right now. Mr. Baxter, are you in the meeting? All right, so if he joins a little later, maybe we can give him time to introduce himself to the board. But we're glad definitely to have someone from the consumer representative area be part of the board. And then also, lastly, I wanted to give updates regarding last month's PA reviews. So the prophylactic treatment for hereditary angioedema PA, as well as Adzynma, Cablivi, Pigray, and Udexta are now available online for the public, for providers to view. And the monoclonal antibodies for atopic dermatitis PA will be posted, I was told, by tomorrow, October 10th. And that is all in terms of housekeeping.
Thank you very much. Next on our agenda to review and approve our minutes from the September meeting. Hope everybody's had a chance to look at those. Are there any comments, edit suggestions for the September minutes?
I move to approve.
All right, second, please.
Second.
Thank you. All in favor of approving the September minutes, please say aye. Aye.
Aye.
Thank you all. And we will move on to item number 2 on our agenda, please. Looks like it's you, Luis, again. We have, unless we've already covered those prior authorization updates.
Yes, Dr. Weinstein, sorry, I jumped the gun on that one. But
no, that's okay. Just making sure I don't skip one. Then we can go to our P&T committee update.
Good morning, everyone. So the P&T committee met last month to discuss the botulinum toxins for approved and non-cosmetic medical use. They vote to include certain product and added that to the PDL, the P&T committee. And for the next month, the P&T committee will meet again to discuss the non-factor hemophilia treatments. Thank you.
That's our update, and we thank you very much. And then I think we are on to our main items for agenda today. We have a review topic. I think Monet will be on to talk about oral buprenorphine for pain. Thank you.
Yep, thank you so much. Good morning, everyone. The goals of today's presentation are to discuss recent guidance on the use of buprenorphine-containing products, abbreviated BCPs, for the treatment of pain and the use of combination opioid therapy. We will also review utilization data for the concomitant use of sublingual BCPs with short-acting opioids in the Utah Medicaid fee-for-service population. Opioids are a heterogeneous group of medications with agonist activity at the mu opioid receptor, which is attributed to major opioid effects, including pain relief and respiratory depression. Most opioid analgesics are full agonists at these receptors, whereas buprenorphine is a partial agonist. Prescription opioids are associated with many serious safety concerns, including the potential for abuse and for life-threatening central nervous system, or CNS, and/or respiratory depression. The risks are most concerning in patients taking high doses of full agonist opioids, abbreviated FAOs, and are those with predisposing conditions for respiratory depression or overdose, including the co-prescription of other CNS depressants. Most FAOs are Schedule II controlled substances, whereas buprenorphine is a Schedule III controlled substance. Compared to many FAOs, especially at moderate to high doses, buprenorphine may be associated with a lower risk for some opioid-related adverse events owing to its receptor binding profile and other unique pharmacodynamic properties. This includes lower risk of respiratory depression, reduced dysphoria and psychomimetic effects, reduced physical dependence, lower euphoria and abuse potential, and lower risk of opioid-induced hyperalgesia. There are many unique BCP formulations available in the U.S. Of the oral BCPs, only the buprenorphine buccal film, Belbuca, is FDA approved for pain, whereas the other oral BCPs are approved for the treatment of opioid dependence, a term related to opioid use disorder, or OUD, that was used in earlier editions of the Diagnostic and Statistical Manual of Mental Disorders. According to prescribing information, the safety and effectiveness in pediatrics has only been established for the immediate release injectable. As of September 2025, most BCPs have preferred status either as a generic or branded product on the Utah Medicaid Preferred Drug List, or PDL. Of the non-injectable BCPs FDA indicated for pain, only the buprenorphine transdermal patch, Butrans, is preferred. Regarding the FDA recommended dosing regimen for oral BCPs, Belbuca, which is indicated for pain, is administered twice daily, whereas the sublingual BCPs for OUD are administered once daily. While the labeled maximum recommended daily dosage of buprenorphine as Belbuca is 1.8 milligrams, the maximum for most sublingual BCPs for OUD is much higher at 24 milligrams. Differences in the maximal recommended dosage suggest that lower but more frequent doses of buprenorphine are sufficient for pain relief and higher doses are needed for OUD. Differences in buprenorphine exposure between dosage forms and administration routes could also contribute to differences in recommended dosing regimens between oral BCPs. However, based on indirect comparisons, pharmacokinetic differences between oral BCPs are generally modest. In general, buprenorphine bioavailability is slightly greater with the buccal route than the sublingual route, and the films yield slightly higher buprenorphine exposure than the tablets. We reviewed recently published U.S. or U.S.-affiliated guidelines on the use of opioids or the treatment of non-cancer-related pain in adults for information pertaining to the two focus questions. We were asked to determine whether there are guideline recommendations about which opioid combinations could be used for pain management, and whether there are recommendations regarding buprenorphine for pain management in ambulatory patients without OUD. After screening many guidelines, only 3 were found that made explicit recommendations or statements about our focus questions, 1 each from the American Society of Interventional Pain Physicians, or ACIP, the Centers for Disease Control and Prevention, or CDC, and the Department of Veterans Affairs, Department of Defense, or VA/DoD. Notably, these 3 guidelines focus on opioid prescribing in general rather than on opioid use in the context of a specific disease condition. Other reviewed guidelines that addressed opioid therapy tended to address opioids as a class without information specific to our research questions. The next couple of slides summarize recommendations or statements that we inferred to mostly apply to patients without OUD, but in some cases may also apply to patients with OUD. For insights related to patients with OUD, we additionally reviewed a 2020 guideline by the American Society of Addiction Medicine, or ASIM. Of the 3 guidelines, only the VA/DoD provided a graded recommendation about buprenorphine for pain. They recommended buprenorphine over other opioids in patients receiving long-term opioid therapy for chronic pain because it is considered to have a better safety profile. Additionally, the VA/DoD suggests that buprenorphine naloxone is preferable for concurrent management of pain and OUD. ACIP suggests buprenorphine as an alternative to strong FAOs for the treatment of moderate to severe chronic non-cancer pain. The CDC suggests buprenorphine for patients who struggle to taper off FAOs. None of these 3 guidelines explicitly recommended a particular buprenorphine formulation for treating pain in patients without OUD. Guidance for selecting a particular BCP for chronic pain management was updated by experts from the VA/DoD in 2024, which supports off-label use of sublingual BCPs, particularly for patients who may benefit from higher buprenorphine doses, such as those transitioning from high-dose long-term opioid therapy and patients with behavioral concerns without OUD. In patients without indications for higher dose buprenorphine therapy, the VA/DoD guideline algorithm suggests using the buprenorphine formulations approved for pain. This guidance acknowledges that evidence for the off-label use of sublingual BCPs in patients without OUD is limited to retrospective observational studies. The 3 guidelines by the CDC, ACIP, and VA/DoD made no graded recommendations about the concurrent use of different opioids or different opioid formulations for pain in patients without OUD, and they provide little explicit informal guidance about concurrent use. Both the CDC and ACIP advise caution while using immediate release or short-acting and extended release or long-acting opioid products concurrently due to an increased risk of overdose, and thus generally suggest limiting combination use to situations in which the benefits outweigh the risks. Nonetheless, such combination therapy may be cautiously considered for certain clinical scenarios, such as during transitions from a long-acting opioid to a short-acting opioid, or for managing post-operative acute pain in a patient on an established long-acting opioid, or for acute pain in patients receiving methadone or buprenorphine for OUD, which is typically carried out in supervised treatment settings. While these scenarios are generally temporary, none of the reviewed guidelines explicitly recommended against longer-term use. Additionally, no guidelines expressed which types of opioids to be used in combination therapy in patients without OUD. In patients with OUD managed with a BCP, the addition of a short-acting FAO can be considered for purposes of treating severe acute pain according to ASIM, but this is a treatment option that should be considered in a supervised healthcare setting. ASIM did not make a recommendation about co-use in ambulatory settings due to a lack of evidence. While non-opioid options are inappropriate, alternatives to adding an FAO for acute pain in patients with OUD include increasing the total daily buprenorphine dose and administering the split doses more frequently, or adding as-needed buprenorphine doses to the patient's regular regimen for OUD. A split dose regimen of buprenorphine is also recommended by ASIM for patients with co-occurring OUD and chronic pain. Because buprenorphine has a higher affinity for mu-opioid receptors than most other opioids, there's a theoretical concern that combination use could undermine the effectiveness of FAOs. However, at steady state levels within the typical dosage range, buprenorphine does not usually occupy all mu-opioid receptors, depending on dose and time since administration. The recommendations by ASIM for managing severe acute pain with concurrent buprenorphine in an FAO implies that FAOs can be effective despite ongoing buprenorphine therapy. Similar to ASIM's recommendations, experts advise that FAOs can be added to BCP therapy for perioperative pain management in patients with OUD. Yet evidence to support these practices in the outpatient setting, particularly in patients without OUD and in patients established on an FAO first instead of buprenorphine, seems limited. Now I will discuss our cross-sectional descriptive analysis with the main objective to determine occurrences of concomitant use of a sublingual buprenorphine-containing product, abbreviated BCP, with a short-acting full agonist opioid, abbreviated FAO. First, we identified Utah Medicaid patients with at least 1 month of fee-for-service coverage who filled at least one outpatient pharmacy prescription for either a sublingual BCP or an oral short-acting FAO at any time during the study period, hereafter referred to as the at-risk population. The date of the first qualifying prescription fill was assigned as the index date. Because we were interested in patients with concurrent use who did not have cancer or received palliative care or hospice, we excluded patients who had those types of diagnosis codes on or within 6 months prior to the index date. However, because not all patients may have Medicaid eligibility or observable data during the entire 6 months prior to the index date, we stratified patients according to their fee-for-service eligibility. The fully observable cohort had at least 6 consecutive months of pre-index date eligibility, whereas other cohorts had lesser months of eligibility. Patients in each cohort were then divided into 2 subgroups based on possible OUD or POUD status. Patients with POUD were defined as those with at least 1 claim submitted with a code for any opioid-related condition, including opioid use, dependence, or abuse at any time during their entire record. The term possible is used because we cannot confirm that patients in the POUD category had true OUD based on these codes alone. Because the fully observable cohort has the most reliable observation period, I'll primarily focus on describing select characteristics and results for this cohort. Notably, the fully observable cohort comprised of 58.1% of all eligible patients. All included patients were adults, with most patients eligible for fee-for-service coverage for the majority of the study period. Among the subgroups of the fully observable cohort, a higher proportion of the POUD subgroup was male and had greater pre-index date claims for substance use disorders, neuropsychiatric disorders, and chronic pain disorders. In the 6 months prior to the index date, over half of patients filled a prescription for an FAO in both subgroups, and about 54% of patients in the POUD subgroup filled a BCP prescription, compared to only about 1% in the no POUD subgroup. The primary outcomes were the proportion of patients with and the incidence rate of a combination use occurrence of a sublingual BCP and short-acting FAO. This slide shows a visual example of a combination use occurrence according to the definition used for the primary analysis, which was defined as an overlapping day supply by at least 1 day of a sublingual BCP and an oral short-acting FAO, with an allowance for up to a 5-day gap between successive fills of medications within the same class, contributing to the same combination use occurrence. Thus, in the example shown on the slide, although 2 separate overlapping periods of a short-acting FAO with a sublingual BCP are observed, they are counted as the same combination use occurrence because the gap between fills is within the 5-day allowance. The permitted gap days are used to reflect an ongoing regimen. Notably, we also performed a sensitivity analysis that did not allow any gaps between successive fills of medications in the same class. Thus, in the same example, two separate combination use occurrences would be counted for the sensitivity analysis. Of all eligible patients for our study, which was almost 7,000, 103 or 1.5% had a combination use occurrence. In the combination use group, the median number of occurrences was one event per person in the 12-month study period. Of the fully observable cohort, less than 67 patients had a combination use occurrence. 56 patients had at least one combination use occurrence in the POED subgroup, which represents about 3% of the fully observable cohort, compared to less than 11 patients in the no POED subgroup, which represents less than 0.5% of the fully observable cohort. Additionally, the incidence rate of combination use occurrence events was significantly higher in the POED subgroup than the no POED subgroup. The length of patients' longest combination use occurrence interval during the period was estimated using two definitions. One, the total interval length, which included overlapping and non-overlapping days with gaps of up to 5 days during a combination use occurrence interval, and two, total overlapping days during the interval, which excluded non-overlapping days. Among those with an observed combination use occurrence during the study period, the median length of each patient's longest overlap was relatively short, however, with some variability. The most frequent longest interval range, accounting for at least 32% of patients with an overlap, was 1 to 3 days, regardless of the length definition used. Among the fully observable cohort with at least one combination use occurrence, the estimated length of the longest combination use interval in the POED subgroup tended to be slightly longer and more variable than in the no POED subgroup. The median length was 6.5 days in the POED subgroup and 5 days in the no POED subgroup. The buprenorphine sublingual tablet was the most frequently involved sublingual BCP by patient count among all patients with an overlap. Combinations involved 6 different FAO active ingredients, with the most frequent being oxycodone. The most frequently observed combination by patient count was buprenorphine sublingual tablets or oxycodone tablets, filled by approximately 45% of patients with a combination use occurrence. Limitations of our descriptive analysis should be considered when trying to make inferences from the results. Combination use of sublingual BCPs and short-acting FAOs was inferred based on pharmacy claims data, which may not accurately reflect actual patient usage. Notably, only sublingual BCPs and short-acting FAOs filled between the index date and the end of the study period were considered for possible combination use occurrences and length. Yet, it is possible that some of the occurrences continued beyond the study period and may therefore be artificially shorter. Moreover, prescription fills during the non-fee-for-service eligibility in the study period were not capturable by our analysis. Additionally, it is possible that the patients classified with possible OUD may have had longstanding opioid use and/or physical opioid dependence, but not necessarily OUD, and some with a history of OUD coding, but that occurred long ago, may have been in remission. Lastly, we did not examine the indications for combination use. Overall, our data review of prescription claims suggests that few patients who filled a sublingual buprenorphine-containing product and our oral short-acting full agonist opioid may have used them concurrently, and that the estimated length of apparent co-use was relatively short. In the fully observable cohort, the group with the most reliable observation period, most apparent co-use cases were among patients with possible OUD. Very few patients with overlapping day supplies without OUD-related diagnoses may represent possible off-label use of sublingual buprenorphine-containing products for the treatment of pain or to help taper off short-acting full opioid agonist. The latter is a recognized off-label use of buprenorphine in guideline. It is also possible that the short intervals of supply overlap observed could represent a switch in therapy rather than intended concurrent use, thus some cases may be misclassified as concurrent users. Our cross-sectional study design using administrative claims data prevents making any firm conclusions about the appropriateness of possible combination use of sublingual buprenorphine-containing products and short-acting full agonist opioids in the fee-for-service population, potentially warranting future investigation. This concludes the presentation. Thank you for your time and attention.
Any questions from our board members or participants today? I want to thank you very much for that presentation. It's of particular interest to me, as this is an area of focus for me in my practice right now. We have many patients on high-dose agonist therapy, some of whom have been on significantly high morphine equivalents for decades, more than 20 years, some of them. And in the process of converting them from full agonist therapy to buprenorphine products, some of which are off-label, my hope is that with enough accumulated experience, we'll be able to get some of that out into the literature with a suggested clinical guideline. But there's not very much in the literature, and I think this is instructive to see what questions arise, and is there a lot of practice in the community for concurrent therapy. I personally, again, this is practice and in clinical opinion. I don't see very much indication for long-term concurrent therapy, but there are many situations where there might be overlaps over days to weeks, and I think the community practice, might require more education about how to do that, and that may be why it's not happening so much. I don't know if that's people are remaining on agonist therapy, or they may be managed in addiction clinics or in primary practices where they're going directly to buprenorphine products. I don't know, Dr. Siegfried, if you or if anybody else has any perspective on that. I think it's a really fascinating discussion. I don't want to take up more time than we have, but if other folks have interest in pursuing this, or if there's more we can learn from our Medicaid data, I think now would be the time to make suggestions. Again, thanks very much for that presentation. If we have no other thoughts or comments, then I'll say think on it, and more than welcome to provide further input as time goes on. Do we need to take an action, Luis, on this?
No, we don't
on
need to take an action, Dr. Weinstein. It's more informational.
Oh, okay. We did have the option on the agenda, just making sure.
Thank you.
Okay. Next up on our agenda, we have a public comment, item number 5. If there is someone from Pfizer on the Hemfazi.
Yes, I'm here, Dr. Weinstein.
Thank you.
Would you like me to start?
Yes, if you would, please. And we do have a 3-minute timer. Somebody, I think, will be
Yes,
watching.
I have it, Dr. Weinstein.
Thank
Go
you.
ahead, Dr. Wynn.
Yes, thanks, Luis. Thanks, Dr. Weinstein. And good morning to the committee. My name is Min Nguyen. I'm a licensed pharmacist and part of Pfizer's medical affairs group. I'm here to provide some information for Hemfazi. Hemfazi is a tissue factor pathway inhibitor antagonist indicated for routine prophylaxis to prevent or reduce the frequency of bleeding episodes in adult and pediatric patients 12 years of age and older with hemophilia A without factor VIII inhibitors or hemophilia B without factor IX inhibitors. Himpavzi is a human monoclonal immunoglobulin IgG1 antibody. It's supplied as a sterile, preservative-free solution for sub-Q administration in a 150 milligram per ml single-dose pre-filled pen. The recommended dosage for Himpavzi is a 300 milligram loading dose by sub-Q injection, followed by the maintenance dose of 150 milligrams once weekly subcutaneous injection on the same day each week at any time. Dose adjustment to 300 milligram sub-Q injection weekly can be considered in patients weighing greater than or equal to 50 kilos when control of bleeding events is judged to be inadequate by the healthcare provider. Based on its mechanism of action, Himpavzi may cause fetal harm when administered to a pregnant woman. The most common adverse reactions reported in the clinical trials do include injection site reactions, headaches, and also pruritus. The efficacy of Himpavzi was established in 116 adult and pediatric patients aged 12 years of age and older and weighing 35 kilos or more with severe hemophilia A or B without factor 8 or 9 inhibitors, respectively, enrolled in the BASIS study, an open-label, multi-centered, two-phase study. Patients entered a 6-month observation phase and were enrolled to 2 cohorts based on the factor replacement treatment they were receiving prior to study entry, either on-demand or routine prophylaxis. Patients completing the 6-month observation phase entered this 12-month active treatment phase, receiving 300 milligram loading dose, followed by 150 milligram once weekly maintenance dose. Himpavzi prophylaxis met its primary endpoint of annualized bleeding rate for treated bleeds during the 12 months active treatment phase in both the on-demand factor-based therapy cohort and the routine prophylaxis cohort. Thank you for your time and consideration for Himpavzi for your Medicaid patients in Utah. I'm happy to answer any questions the committee might have.
Thank you. I think we will come back to that shortly. Shall we proceed to our review of the prior authorization criteria? I think we have Omnipod first up.
Good morning, everyone. Is everyone able to see my screen?
Looks good.
Perfect. Okay, so let's begin. The first thing that we have is other insulin pumps are available under the Durable Medical Equipment DME benefit. To begin with, the criteria is a disposable insulin pump system being prescribed by an endocrinologist or in consultation with a provider specializing in the treatment of diabetes mellitus. And it's for infusion of at least 5 units of insulin per day. And then we ask that they provide the total daily dose. For number 2, does the patient and or caregiver adhere to a comprehensive diabetes treatment plan supervised by the treating provider, and can they recognize and respond to the messages, alarms, and alerts of the device? Does the provider attest that the patient is not pregnant, on dialysis, or critically ill? Does the provider attest that the patient and or caregiver has received or will receive appropriate ongoing counseling and training for Omnipod use? Will Omnipod 5 be used in conjunction with a compatible and Utah Medicaid preferred continuous glucose monitor? Has the patient been using another insulin pump other than Omnipod within the last 5 years? And then we ask that they provide the details of that insulin pump. And then for additional criteria for type 1 diabetes, is the patient 2 years of age or older? And for type 2 diabetes, is the patient 18 years of age or older? Does the member meet one of the following criteria? The patient requires 3 or more insulin injections per day and has a hemoglobin A1C of at least 7%. And the patient requires 4 or more blood glucose tests daily, or is utilizing a CGM or continuous glucose monitor for at least 3 months. And then we ask that they provide what CGM they're using. or the patient has a history of hypoglycemia with dawn phenomenon, with fasting blood sugars frequently exceeding 200 milligram per deciliter, hypoglycemic unawareness or nocturnal hypoglycemia, or the patient has a loss of manual dexterity. And for the reauthorization criteria, has the provider submitted an updated letter with medical justification or updated chart notes demonstrating positive clinical response? And for both initial and reauthorization, it's approved for 1 year or up to 1 year. Any questions or concerns?
Questions or comments from the board? Shall we have a motion to approve the PA as presented?
So moved.
Thank you. Do we have a second?
I'll second.
Thank you. All in favor, please say aye.
Aye.
Aye. Thank you very much. Let's move on to, I think, Luis, you are going to review the PA criteria for Zavaskin.
Yes, that is correct. Let me
Thank
pull that
you.
up. All right, so starting with number one, it says, is the patient 6 years of age or older? Does the patient have a diagnosis of recessive dystrophic epidermolysis bullosa or RDEB, confirmed by genetic testing? And then under that, there's specific requirements. So biallelic pathogenic mutations in the COL7A1 gene, and also positive expression of the non-collagenous region 1 of the 7 collagen protein, NC1 plus. Is the medication being prescribed by a dermatologist specializing in the treatment of recessive dystrophic epidermolysis bullosa? Does the patient have at least one chronic wound size of greater than or equal to 20 centimeters square, open for greater than or equal to 6 months, associated with RDEB? Does the provider confirm that the patient does not have current or history of squamous cell carcinoma at the treatment site? Does the provider attest that the patient has not been previously treated with Zavaskin? And has the patient tried and failed both Vyjuvek and Filzuves for at least 6 months for each treatment? And the treatment is authorized as a one-time, up to 12 sheets can be authorized for this particular intervention. And that is all the criteria. Are there any questions? And this one is an ultra high cost drug as well.
Just one thing just appeared to me here on number 7. Those are trade names for both of those. Do we usually put generic names in parentheses on these, or do we refer to always to our manufacturers' names on these PAs? I mean, I don't imagine there'll be generics coming on these anytime soon, but it's just a question.
No, I think that's a good idea just to avoid confusion. We'll put the generic names in parentheses for each one.
Okay, thank you. Any other comments or questions, edit suggestions from the board? If not, we'll take a motion to approve as amended.
So moved.
Thank you.
I'll take it, Dr. Siegfried.
Moved and seconded. Thank you very much. All in favor?
Aye.
Aye.
Aye. Thank you. And now we'll come to the discussion on Himpavzi.
Okay, good morning, everyone. I'll present Himpavli Marstacimab. So the first one is a patient 12 years of age or older. Does the patient have a diagnosis of either of the disease listed below? They have hemophilia A without factor VIII inhibitor, hemophilia B without factor IX inhibitor. Is a medication being prescribed by or in consultation with a hematologist for prevention of bleeding episodes? If the patient has reproductive potential, does the provider attest that the patient is not pregnant? And then that can provide the details on the pregnancy test. And has the provider advised the patient to use effective forms of contraception during and for 2 months after the last dose of the treatment? And then they can provide details on the contraception methods. Does the patient have at least one of the following? Prophylaxis with factor VIII or factor IX clotting agents was not effective. The patient has poor venous access. The patient failed to achieve an adequate trough level while on optimal dose of factor VIII or factor IX clotting agent. The patient had serious side effects, FDA labeled contraindication or hypersensitivity to factor VIII or factor IX clotting agent, and then they can provide details. If the patient is currently taking prophylactic clotting factor replacement therapy, does the provider attest that the patient will discontinue the clotting factor concentrate before initiating marstacimab? Does the provider attest that the patient does not have the following: history of coronary artery disease, venous or arterial thrombosis, ischemic disease? And for reauthorization criteria, has the provider submitted an updated letter with medical justification or updated chart notes demonstrating a positive clinical response? And for initial authorization, you will be approved up to 6 months, and for reauthorization, you will be authorized up to 1 year. Okay, any questions or comments?
Might I just ask our pediatric colleagues on the board, just looking at number 4, is a comment that the patient is not sexually active considered a form of contraception?
I know that for other medications that you have that have a pregnancy risk, we'll do pregnancy testing. One of the issues, of course, as you know, in pediatrics and possibly in adult world too, is the non-consensual sexual activity. And so, I think that that pregnancy test they have on here is likely going to be an appropriate thing if the risk is considered high enough. What do you guys think? So, I mean, anyone of reproductive age should be on contraception and have routine pregnancy tests if they're taking a medicine that has high fetal risk. Does this meet that criteria for that kind of medication?
So a 12-year-old who's not routinely sexually active would be on some form of contraception for while they're being prescribed this. That would be considered routine practice. It's my curiosity. I don't know what the standards would be.
Yeah, I don't know the standard either, but if you have someone who can be sexually, who can conceive, and if it's a high risk medication, like think of Accutane, right? Then you need to have some type of protection for them. And if that falls into the category, then it looks like this would cover those things with the pregnancy testing and the contraception recommendations. And we do, as you know, we do birth control pills and for hormonal regulation in many different ages, and they're well tolerated in those settings. And so, And I actually don't know if our hemophilia families, if they, if this is also used as a way to help control that bleeding as well. That's something I'm not a hemophilia expert. Is there already some routine use of controlling menstrual cycles for our hemophilia women? I don't know.
Thank you. My education always in this board. Appreciate that. Any other comments or questions, suggested edits? If not, I'll take a motion to approve the PA as presented.
Move to approve.
Second.
Thank you. Thank you both. All in favor, say aye, please.
Aye.
Okay, thank you very much. We were efficient today, and I appreciate everybody's participation and contributions to the meeting. We will be meeting again in November. We have at least one topic already projected for the agenda. Luis, anything else before we ask for a motion to adjourn?
No, Dr. Weinstein, that is everything. Thank you so much for your help, and thanks to the DURB board for helping us out today.
Yes, and thank you to our presenters. I'll take a motion to adjourn and give us a few minutes back to, I know you're a very busy day.
Motion to adjourn.
Thank you. Second?
Second.
Thank you all. Have a wonderful day. Stay safe.
Thanks, Sam.
See ya.